I know you got a lot of material to cover. So good morning, everyone, and welcome to our weekly CMR conference series hosted at VCU. Very pleased to be welcoming Dr. Shaimaa Fadl, who's an assistant professor here in our Department of Radiology at VCU, and quite a wonderful resource for all things clinical CMR, and stays quite active in the research space as well. And so she's going to be speaking to us on using CMR towards hereditary cardiomyopathies, and she's published in this space before. Just a reminder to everyone that these are CME and MOC accredited sessions, so don't forget to text the code on the screen to the number provided. And Shannon, this one's not ASRT, right?
Correct.
Okay. So we'll have some more of those in the future for our MRI technologists. But with that, I'll go ahead and turn it over to Dr. Fadl. Thanks again.
Thank you so much, Corey, for the invitation and for the introduction. It's always a great pleasure for me to be here in this Wednesday conference meeting. Today, we are going to do some revision about the cardiac MRI features of inherited cardiomyopathies. We will review some common diseases and describe the CMR imaging features and how cardiac MRI plays an important role in the diagnosis, prognosis, and management of those patients. I don't have any disclosures, but I would like to acknowledge Dr. John Grizzard for his support, his sharing wonderful cases all the time. There was a classification for the inherited cardiomyopathies published at the New England Journal, and it's based on the morphology. Some have thick myocardium, hypertrophic. Some have dilated cardiomyopathy, thin dilated heart. Some are overlapping. Some have just a normal wall thickness, but just arrhythmogenic cardiomyopathy. Some have normal wall thickness, but not well contracting or have strain abnormalities like restrictive cardiomyopathy. Left or morphologic non-compaction, which is overlapping also between some of the other morphologic classifications. The American Heart Association had different classifications, genetic of primary cardiomyopathies, genetic versus acquired, and some mixed in between. The genetic have most of the diseases. The mixed between the acquired and genetic are dilated and restrictive cardiomyopathies. This is an illustration of the cardiac myocyte with the different genes encoding for different proteins. This is the sarcomere proteins, and this is the common genes associated encoding for this protein. Any disruption of these genes will lead to different types of inherited cardiomyopathies. This is the dystrophin complex with the with abnormalities that you can see associated with Duchenne muscular dystrophy. The desmosome proteins, which you see if disruption of these genes encoding for this proteins, you will see that associated with arrhythmogenic cardiomyopathy. Lysosomal proteins, like in patients with Fabry disease and patients with Danon disease. Nuclear proteins, like in patients with myotonic dystrophy. We will do some quick revision, a basic revision of most of these diseases. I have the rest of my colleagues presenting most of each disease in a different lecture, so it's hard to connect to all of them, but we will just review the most important imaging features, prognostications of the cardiac MRI. Starting with the most common is HCM, hypertrophic cardiomyopathy. Which one of the CMR features is more common in sarcomere positive HCM patient? Do you think it's LVOT obstruction, reverse septal morphology, or less LGE, or less interstitial fibrosis? And let's see the answer. So Some of you thought that it's LVOT obstruction, but in patients with with sarcomere positive genes, the most common feature that you can encounter is reverse septal morphology. We will describe some of the differences between sarcomere positive patients versus sarcomere gene negative patients. So starting with HCM, it's the most common. It's 1 in every 200. Previously described or published in 1 in every 500, but it's more than this. It's like in every 200. It's autosomal dominant with variable penetrance. You may have a father that has apical HCM presenting at the age of 50, or a son that presenting with concentric hypertrophy at the age of 20. So it's variable penetrance of the disease. And the common genes associated with it is myosin heavy chain 7 and myosin binding protein C3. And it's characterized by myocyte hypertrophy associated with myofiber disarray and fibrosis. Regarding the cardiac MRI features, wall thickening, and the cutoff that we consider LV wall thickening is suggestive of HCM is more than 15 millimeter, but you lower that threshold in patients with gene positive, in patients with genetic positive testing. You lower it to 13 millimeter. Elevation of the LV mass index, but keep in your mind that 20% of HCM patients may have a normal mass index. Cavity obliteration during systole, this is one of the features, and HCM may have morphologic variations. This is one of the patterns of HCMs is reverse septal morphology, or what we call spiral morphology of the septum, that the thickening of, this is a patient with abnormal thickening of the septum, but when you go to the base of the heart, you will find that thickening starting from the from the septal wall and going from the anteroseptal wall to going to the mid segment along the inferior septal wall, and it's in a spiral fashion or anti-clockwise. You'll see it going to the apical segment most commonly along the inferior wall. These are the morphologic variations of HCM: asymmetric septal hypertrophy, concentric hypertrophy, apical predominant, biventricular HCM involving the RV, mass-like HCM, which is problematic with patients that you are not sure this is a mass versus mass-like hypertrophy, or non-hypertrophic variant. Like just highlighting some of the features of asymmetric septal variant is that involve asymmetric thickening of the septum, and it causes some narrowing of it may cause some narrowing of the left ventricular outflow tract, LVOT narrowing. And you can see in this patient with the 3-view CNA image, you can see acceleration of the flow through the LVOT, which with subsequent anterior tethering of the anterior leaflet of the mitral valve and subsequent opening of the mitral valve during systole with subsequent mitral valve regurgitation, what we call SAM, systolic anterior motion of the mitral valve leaflet. So this patient had narrowing of the LVOT, SAM, and mitral regurg associated with the asymmetric septal hypertrophy of the left ventricular myocardium. You can obtain the LVOT gradient, and usually more than 50 is warranting a septal reduction therapy and can be associated with increased adverse event risks. Another highlight for the presence or absence of apical aneurysms, particularly in patients with apical variant or mid to apical variant HCM. Those patients, the presence of apical aneurysm is reported to be associated with major adverse events or a risk of sudden cardiac death, such as in this patient. Regarding the enhancement or late gadolinium enhancement pattern, in HCM patients, the characteristic enhancement pattern is along the RV insertion sites, mainly at the septum, or along mid-patchy enhancement at the thickest myocardium. Like if this is asymmetric hypertrophy, you'll see the more enhancement along the septum if this is the most thickened portion. And it can be really helpful in some of the patients, like in this patient with genetic positive HCM, but at the same time has normal wall thickness. But you can see the characteristic enhancement pattern at the RV insertion size for this patient, which goes with a thin filament or gene positive HCM. The presence of LGE more than 15% has associated with more adverse event, like almost the risk is doubled once you reach 15%. In more than 20 is, you can see how it is really increasing significantly the risk of sudden cardiac death. Elevation of T1 and ECV values correlate with the presence of interstitial fibrosis, and you can see it sometimes in areas without LGE. So it also may help increase the prognostication of the value of prognostication of the cardiac MRI that this patient may have more interstitial fibrosis. Regarding the differences or the reported differences between the sarcomere positive or gene positive HCM versus gene negative HCM, you can just remember that the spiral septal morphology, which is usually does not have association with LVOT, or it's anti-clockwise, or what we call reversal septal morphology, spiral morphology, is one of the features. But note that you can see more LGE or more elevation of the T1 and ECV values in those patients, indicating more interstitial fibrosis. And the opposite, you can see it in sarcomere negative patient. Those patients are more associated with isolated basal septal hypertrophy, more which with subsequent more LVOT narrowing, but they are less having less LGE and less interstitial fibrosis. So cardiac MRI play an important role in risk stratification with the presence and extent of LGE correlate with the risk of sudden cardiac death. Regarding our next on the list is Fabry disease. And what is the characteristic enhancement pattern in Fabry disease? Is it mid-wall LGE at the basal inferolateral wall? Is it subepicardial LGE? Is it subendocardial LGE? Is it transmural LGE? And we can give a few seconds. And the image is a patient with a Fabry disease. And most of you got the answer correct, mid-wall LGE of the basal inferolateral wall. Excellent. So it's a rare disease. The reports and the literature varied between 1,600 to more than 1,700. So it's really variable, but it's uncommon. It's X-linked lysosomal storage disease. Its deficiency of the alpha-galactosidase enzyme will lead to accumulation of the glycosphingolipids within the myocardium. But it's always also associated with extracardiac manifestations, so we can pay attention, like renal disease, cutaneous angiokeratomas, neurologic disorders, and ophthalmologic changes. So this is an example of a patient with Fabry disease with the mid-wall LGE at the basal inferolateral wall. Regarding the CMR findings, LV hypertrophy is one of the features. The presence of LGE at the basal inferolateral wall, mid-wall, is very characteristic. It spares the immediate endocardium. The native T1 values, because it's a glycosphingolipids, you can guess that it is having low T1 values, particularly early in the disease before developing of scarring and fibrosis, where the native T1 values start to increase. This is an example of a patient with Fabry disease, and you can see that this septal wall is having the disease and showing low native T1 values along the septum, but because of the LGE and increasing areas of fibrosis along the lateral wall, you can see that these values along the lateral wall are elevated. This is another example showing the thick myocardium in patients with Fabry disease. This is the normal patient. This is a Fabry disease patient, and you can see the low native T1 values throughout the myocardium, but the focal area of scarring or fibrosis showing elevation of the T1 values, that red spots, and it corresponds to the LGE area. So low native T1 values early in the disease is characteristic. The LGE pattern is characteristic, but it also helps us in differentiating that thick myocardium with infiltrative disease from the hypertrophic cardiomyopathy or from the cardiac amyloidosis based on the enhancement pattern. Cardiac MRI plays an important role. Those patients are treated usually by enzyme replacement therapy, and a CMR predict the treatment response by the if this patient is not having any LGE, usually the treatment response is excellent. But with the presence of LGE, you will start to see that those patients may have lesser degree of treatment response. Patients with no LGE, you'll see that the most significant reduction of the LV mass after the treatment, most improved function, and most improved exercise capacity compared to the patient with the areas of LGE. So LGE at the basal infralateral wall is characteristic. T1 values are low earlier in the disease, and MRI can predict treatment response. Regarding cardiac amyloidosis, familial type, what's the enhancement pattern in transthyretin cardiac amyloidosis? Is it mid-myocardial? Is it subepicardial? Is it global subendocardial? Is it patchy enhancement at the RV insertion sites? A few seconds. We can okay, great. Most of you got it correct. Global subendocardial enhancement. The age of presentation of the transthyretin type is variable from 30 to 80 years old. It's autosomal dominant disease, but it has also, again, variable penetrance. It can show an early age or very late in age. Pathology is usually the pathophysiology of that disease, that it is abnormal folding and deposition of the transthyretin protein into different organs, including the heart. The characteristic cardiac MRI feature involve significant wall thickening of the myocardium, could be the RV and LV as well. Increased myocardial mass, atrial wall thickening more than 6 millimeters, biatrial enlargement, and the presence of pericardial and pleural effusions are very characteristic. One of the other features is abnormal gadolinium kinetics in the TI scout or locker sequence. Usually the normal that the blood pool nulls before the myocardium, but with the presence of amyloid protein deposition, you may see nulling of the myocardium before or at the time of the blood pool is considered abnormal in those patients. This is how it shows abnormal myocardial nulling occurring before the blood pool. I think that percent I have to change it. It's depending on so many factors, and it's challenging in some patients. But you can, when I slow it down, you can see that when you apply with the gadolinium kinase, you can see the nulling of the myocardium occurring before the blood pool in this patient, which is not normal. Diffuse patchy subendocardial enhancement or transmural enhancement is very characteristic. Another characteristic thing is the enhancement of the atrial wall. I find that it's really helpful in some patients. And there are some suggestions of features that can be seen more with transthyretin type cardiac amyloidosis or the genetic type, that the enhancement is more extensive. The presence of RV enhancement and the high prevalence of the transmural enhancement versus subendocardial enhancement in light chain type. Patients with cardiac amyloidosis usually have very high elevation of the native T1 values, like in the reported on 1.5 Tesla is more than 1045 milliseconds, and elevation of the ECV values more than 49%. The technetium-99 pyrophosphate is also highly sensitive and specific for the transthyretin type of cardiac amyloidosis. The uptake of, but note that you need to have uptake of the myocardium to call it positive, either, and you can just wait for 2 hours or just doing a SPECT CT to confirm that this uptake is within the myocardium, not within the blood pool. These are some features that on cardiac MRI that may suggest that this is likely that encountered more with transthyretin type compared to the light chain, that the left ventricular hypertrophy is more pronounced, that LGE is more extensive. They usually have higher ECV values compared to the light chain type, where higher native T1 values. The technetium-99 pyrophosphate is positive in transthyretin type, but it's negative in light chain type. They, in cardiac amyloidosis, LGE is usually the subendocardium, but it can be extensive and transmural. The technetium-99 pyrophosphate is positive in patients with transthyretin cardiac amyloidosis. Another, I started usually with a thick myocardium, including the hypertrophic Fabry and cardiac amyloidosis, and this is the first patients with thick heart, Danon disease. Which one is common imaging feature in Danon disease? Is it LV wall thinning and dilation? Is it more common in females? Is it extensive LGE with septal, let me check, with septal sparing? I have never heard about this disease. I think over the last years, there is increased awareness about the genetic cardiomyopathies. So we started to hear about those diseases more frequently than in the past. Because usually it was not really CMR finding that we can tell, but now with increased awareness, we are seeing more patients and more, we are able to diagnose more and more patients earlier. So the correct answer for this patient is extensive LGE with septal sparing. And let's talk about Danon disease. It's an X-linked dominant disease with a genetic defect of the lysosomal associated membrane protein gene. It's one of the lysosomal genes. And it, as a subsequent, those patients develop lysosomal accumulation of glycogen. And usually they present with triad: skeletal muscle disease, myopathies, intellectual deficits, and cardiomyopathy. And the reported EKG association is pre-excitation syndrome or Wolff-Parkinson syndrome. These are very, in young adults. Well, these are characteristic features. On MR, they are characterized by extensive myocardial thickening, extensive LGE. It's non-uniform, but you can, with this extensive LGE, you may think it's HCM, but when we look at those patients, usually the lesser degree of involvement of the septal wall compared to the HCM patients where you have involvement of the septal wall more pronounced than the rest of the myocardium. So extensive, non-uniform, lesser degree of involvement of the septal wall are characteristic features. And this is the difference is, and this is a patient with HCM, and you can see our the enhancement along the RV insertion size, which is the septal wall, more than the lateral wall compared to the Danon disease with that have a little bit sparing or lesser degree of involvement of the septal wall. So massive HCM, pre-excitation conduction EKG abnormality is characteristic features. Extensive non-uniform LGE that spares the septum is another characteristic feature in patients with severe thick myocardium. Familial dilated cardiomyopathy. So it's another common genetic disease. So the most common is HCM and dilated cardiomyopathy. They have higher prevalences, 1 in 2 or 250 of the population. The familial form account half of the dilated cardiomyopathy cases. More than 40 genes are associated with dilated cardiomyopathies, but I'm highlighting titin gene, lamna genes, and other like desmine or desmosomal ion channel proteins. The characteristic imaging features, LV dilation, but could be with or without RV dilation. Functional, because of the dilation of the atrioventricular annulus, you get valvular regurgitation, tricuspid and mitral. Septal wall dysyncrasy, mid-wall LGE is another feature. So mid-wall LGE can be seen, it's like a linear stripe, and the presence of mid-wall LGE is a poor prognostic indication. The other value of CMR is detection of thrombi, because those patients have a stagnation of the blood, have hypertrabeculation of the subendocardial myocardium. So they are more prone to developing clots, and cardiac MRI can help with that. The native T1 and ECV values, I find it's very challenging to be assessed on those patients, particularly because of the very thinning of the myocardium, and because of the, it's very close to the blood pool. But if you think that there is elevation of the T1 values, this is associated with increased risk of adverse events. So in summary, for the dilated cardiomyopathy, linear mid-wall stripe pattern of LGE is characteristic and with poor prognostic indication. Moving to the next disease, muscular dystrophy associated cardiomyopathy. Duchenne muscular dystrophy is associated with mutation of the genes encoding for which protein? Is it desmin protein? Is it dystrophin protein? Is it lysosomal associated membrane protein? Is it thick filament of the sarcomere protein? And let's see the answer. Yes, dystrophin protein is the main protein affected in those patients. So Duchenne and Becker's disease are X-linked recessive. Becker's disease is lesser degree or milder degree of involvement. It's characterized by deficiency or absence of the functional dystrophin protein. In patients with Duchenne, usually the dystrophin protein is absent. In Becker's disease, this dystrophin protein is deficient or less functional compared to the Duchenne muscular dystrophy. That's why it's a milder form of the disease. Duchenne is characterized by progressive skeletal, respiratory, and cardiac failure. The characteristic LGE pattern in those patients is usually subepicardial and mid-myocardial, and particularly the inferolateral wall. So when you see subepicardial enhancement, you'll start thinking, is it myocarditis? This is one of the mimics, but usually the younger age and the scope of the diagnosis, the presence of skeletal myopathies, these things will alert you that this is probably related to the disease rather than myocarditis. Lateral wall infarct, but this patient, this is subepicardial and mid-myocardial enhancement, and usually infarction involve the subendocardium. It's just because of it's involving a certain territory, but it's not the characteristic pattern of enhancement. And those patients, this is a patient with Duchenne muscular dystrophy, and you see there is abnormal wall motion of the lateral wall, and this is the LGE images, and you can see the corresponding subepicardial enhancement along the lateral wall and also the inferior wall. This is a very characteristic enhancement pattern. In patients more than 15 years old, 59 of those patients have LGE already, so they are progressing over the years. The LGE enhancement of the septal wall, if you found enhancement of the septal wall, this is indicative that this is very severe heart disease involvement. The number of segments with LGE is associated with the increased number of segments of LGE is associated with increased risk of mortality, increased mortality rate. So the more segments or the more areas of enhancement is associated with increased mortality. In those areas along the lateral wall, you'll see elevation of the native T1 and ECV values indicative early and diffuse patterns, and also can indicate bad prognosis. So in patients with muscular dystrophy, remembering LGE, subepicardial, and mid-myocardial enhancement pattern, that the number of segments of LGE is a marker of poorer prognosis. Almost there. So next is arrhythmogenic cardiomyopathy. Which one of the following included in the revised task force criteria for the diagnosis of ARVC? The task force criteria is really now is more than 12 years. It was 2010, so it's like 13 years or 14 years. It's very outdated by now. We need more updated criteria. But we are still following the modified task force criteria for the ARVC diagnosis. Do you think it's LG? Is it myocardial fat? Do you think it's focal wall abnormality? Is it RV ejection fraction more than 45? Okay, so the presence of myocardial fat was on all the criteria, but now it's not in the criteria for the diagnosis by MR anymore. And the correct answer is focal wall motion abnormality of the RV free wall. So ARVC, the prevalence is 1 in 1,000 to 5,000. It's usually affecting the genes encoding for the desmosomes, which is the intercellular communication. That's why most of those patients may present with electricity abnormality, like arrhythmogenic arrhythmias, because of the there is disruption of the intercellular communication. Autosomal dominant with incomplete penetrance, like they may not manifest unless the patient exercise or have really severe exercise burden. So it is correlated with the level of the exercise. So that's what we mean by incomplete penetrance. Athletes have early onset and more severe disease than the rest of the. That's one of the explanation of the incomplete penetrance. This is a patient with ARVC. You can see here, this is focal dyskinetic movement of the basal lateral wall of the right ventricle, what we call accordion sign. Cine images are always helpful to detect the focal wall motion abnormality of the RV. And we can make use of the short axis tag for evaluation of the function of the RV and check if it's meeting the criteria. So what's the MR criteria for the diagnosis? MR supplies one of the criteria to the modified task force criteria, but the MRI criteria, we consider major criteria if it is focal wall motion abnormality of the RV with one of the following, either the ratio of end diastolic volume to the body surface area is more than 110 or 100 in females, RV ejection fraction is lower than 40%. It's considered minor criterion if it's focal wall motion abnormality with slight wiggling of the ratio, like 100 to 110 in men, 90 to 100 in females, or the RV ejection fraction between 40 to 45%. Although it's not part of the task force criteria, the LGE is correlate with the wall motion abnormalities in like 2/3 of the patient and many patients. But this patient had the ARVC, enlargement of the RV, enlargement of the right ventricle, and it was akinesis of the RV free wall. And in this patient, we had enhancement of the RV free wall corresponding with the wall motion abnormality. The presence of intramyocardial fat is not one of the criteria for the diagnosis. It can be seen in obese patients. RVOT of elderly patients can be seen in even normal patients. It's not one of the criteria anymore. It has been seen in more than 50% of normal hearts in elderly. So MR is helpful in the diagnosis, supplying one criterion, major or minor, for the task force criteria, which include like familial and other criteria for the diagnosis. Cine images are helpful to detect the focal wall motion abnormality, looking at focal areas of dyskinesis, RVOT ballooning, or aneurysms of the RV free wall. Moving to another type of arrhythmogenic cardiomyopathy, the ALVC, or left ventricular arrhythmogenic cardiomyopathy. This is has been reported with mutation of the desmoglein gene, and it is associated with LV arrhythmias, ECG changes, and late gadolinium enhancement. This is an example of a patient with intramyocardial fat surrounded by a dark ring with India ink artifact because of the fat deposition, and there are subepicardial to mid-myocardial enhancement involving the areas, the lateral wall, inferior wall, septal wall, and it is overlapping the areas along the inferior wall which had the fat deposition. So the characteristic, just remember the presence of intramyocardial fat of the LV. LG is overlapping the areas of the fat deposition. RV enhancement or RV involvement can also be seen in some patients. Sometimes it's overlapping, mixed arrhythmogenic left and right ventricular cardiomyopathy. That's why it's very important that we remember some of the differences, and we need more criteria for the diagnosis. But not in those patients with ELVC, usually the left ventricular function is normal until very late in the disease. The LVEF is usually normal, but if it got lower than 55%, it's strongly associated with severe ventricular arrhythmias. And this is another example with desmoglein mutation and also extensive LG along the lateral wall, inferior wall, and septal wall with subepicardial pattern. The presence of LGE usually is before the systolic dysfunction, and has been reported that those patients may present as myocarditis or elevation of the enzymes like acute myocardial injury in 15%. And there is a proposed criteria in 2020 called PADWA criteria. It meant to update the task force criteria a little bit and include the left ventricular variant of arrhythmogenic cardiomyopathy. And it's considered major criteria by cardiac MRI if you see that LV, LGE, more than 2 segments involving the free wall, septum, or both. Like here, it's more pronounced. So this is a patient with LG. It's a ring-like morphology. They call it stria or band distribution, subepicardial pattern involving the lateral wall, septal wall, and inferior wall, more than 1 segment, excluding the septal, like the RV insertion sites, because RV insertion site can be seen in normal population. So they excluded that enhancement. This is one of the features. And the other thing is the LV function is preserved till the patient later. So ELVC is associated with desmoglein mutation. It's characterized by LV fibrofatty infiltration associated with LV dysfunction and arrhythmias and abnormal delayed gadolinium enhancement. LV non-compaction is, there is disagreement whether it's a classified primary genetic cardiomyopathy on its entity or it's a morphologic trait. In the pathology, they don't, before we thought that it's arrest of the embryologic compaction of the myocardium or the normal compaction process, but there is increased thinking or theories that this is probably proliferation of the subendocardium based on, you can see that proliferation in patients, in athletes or women. So the new theory is it's proliferation of the subendocardium. Usually when it is genetic, it's autosomal dominant inheritance, rarely X-linked inheritance. And the CMR features for the diagnosis, increased hypertrabeculation, increased trabeculation, systolic heart failure, non-compacted to compacted ratio of more than 2.3 at end diastole. Those patients, the value of cardiac MRI is to detect clots or thrombi in association of congenital heart disease or other diseases with the LV dilation. This is like some of the proposed, published proposed CMR criteria for the left ventricular non-compaction. The most common criteria that we all use is Peterson criteria, which is by cardiac MRI, non-compacted myocardium to compacted myocardium on the long axis cine, measured in the long axis cines at end diastole of ratio 2.3 to 1% that most of us are using. There are so many proposed criteria in between, but the most recent criteria or the criteria that has been used for prognostication is Grothoff criteria. Just I'm highlighting that regarding the risk stratification, or that it's used for risk stratification, and usually the percentage of the non-compacted myocardium to the left ventricular myocardial mass is more than 25%. Involvement of non-compacted to compacted ratio of 2.1 in the lateral segments 4 to 6, which are the lateral and inferior wall at the basal segment, or a ratio of more than 3.1 in the remaining segments. So these are the more criteria for the diagnosis, and the amount of is more of the non-compacted myocardium is more than 15 grams per square meter. Imaging pitfalls, the criteria are frequently finding in healthy population, and so it's really challenging for the diagnosis. Apical variant of HCM may be seen in those patients. Dilated cardiomyopathy or apical thrombus may have that hypertrabeculation appearance of the, and that's why it's challenging sometimes to establish that diagnosis. Absence of LGE equal better prognosis. So in LV non-compaction, it is a good, the CMR feature is helpful in ruling in suspected individuals with high test probability for the diagnosis rather than excluding them. The CMR is helpful in detecting apical thrombus that can be present in those patients. Last of our list of diseases today is iron overload cardiomyopathy. Which one of the is a characteristic imaging feature in iron overload cardiomyopathy? Is it LV hypertrophy? Is it increased T2 star signal? Is it low native T1 values? Is it correlation with the liver iron overload? And the correct answer is increased T2 star signal, low native T1 values. So it's the opposite. Yes, T2 star signal is used, but it's low. It should be low, not increased, but the low native T1 values is the correct answer. So why we talk about iron overload in inherited cardiomyopathy, because they may present primary as genetic cardiomyopathy with hemochromatosis patients, or secondary in patients with other genetic diseases like thalassemia or sickle cell diseases with who requires frequent iron overload deposition. And this can be also why we care about iron overload cardiomyopathy. The iron usually deposits along the subepicardial first before it goes to the entire myocardium. But the characteristic finding is that those patients that my LV myocardium is not thickened. The MRI plays a very important role in quantitative assessment of the iron overload. They don't have to do biopsy. It's one of the diseases that cardiac MRI is very diagnostic, or to rule in or rule out the disease. And there is usually differences between the iron overload deposition between the heart and the liver. You see here, the liver is very dark because of the severe iron deposition, but this patient also have my iron overload cardiomyopathy, but usually they don't correlate together. And you can see the darkening of the signal of the myocardium with the multiple gradient echo times here. So we take these multiple echo times, and we draw an ROI along. Usually, those patients are scanned on 1.5 Tesla. There is not enough data that 3 Tesla. Those patients, there is increased ferromagnetic effect on 3 Tesla. That's why there is not much data if someone tried to establish values on the 3 Tesla. So on 1.5 Tesla, we draw a large ROI to involve as much as we can from the septum, because if the iron is deposited along the subepicardial, we try to involve as much as we can. We try to avoid the blood pool. And a values lower than 20 milliseconds is diagnostic. A value of less than 10 milliseconds indicates severe iron overload. And in this patient had a value of 14 milliseconds, which was diagnostic for iron overload cardiomyopathy. The T2 star values correlate with the risk of heart failure. And then the lower the T2 star values, that indicating severe disease and risk of heart failure. Characteristic finding, another characteristic imaging feature is low native T1 values. The iron has a low native T1 values, and this is very helpful in patients with borderline values. Like if the T2 star is 19 or 21, you're not sure, you can see the low native, the T1 values. If it's low, it will be very characteristic in those patients and diagnostic. So it's a non-invasive diagnostic tool for iron overload. T2 star values have high sensitivity. T1 can be helpful in borderline cases, particularly with mild iron overload cardiomyopathy. These are the illustrative gene panels that the runs when they see these cardiomyopathies, HCM, dilated cardiomyopathy, ARVC, and there are different syndromes associated with these different morphology of the cardiomyopathy. But you can see here the diagnostic yield is usually very variable, from 10 to 60%. So putting things together with the cardiac MRI is very helpful in those patients. This is again the illustration of the cardiac myocyte and revision of the sarcomere protein, dystrophin protein, desmosome proteins associated with arrhythmogenic cardiomyopathy, lysosomal proteins such as in Fabry disease or Danon disease, nucleus genes that have like LAMNA, which is in dilated cardiomyopathy, or others with the myotonic dystrophy cardiomyopathy. Thick heart, the LGE pattern is very helpful in those patients. So hypertrophic cardiomyopathy will have the RV insertion sites. Fabry disease will have the mid-wall, basal infralateral wall enhancement pattern with sparing of the endocardium. Amyloidosis with the subendocardial or transmural enhancement is very characteristic. Danon disease with relative sparing of the septum is very characteristic. So when you see a thick heart, the presence of LGE, the LGE pattern help differentiation. Just don't forget about inherited cardiomyopathies in patients, in female patients. They may manifest differently. So CMR plays an important role in the diagnosis of those patients, but know that there are some differences. Screening of female carriers, such as Fabry disease, muscular dystrophy, and rarely Danon disease, is very, I think we started in our institution 2 years ago, like starting to screen those patients more frequently by cardiac MRI. They may present later, may present milder disease, and predominantly cardiac involvement, not necessarily with other extra cardiac findings. That's why those patients are challenging for the diagnosis from the clinical side. Iron overload cardiomyopathy in women carries a lower risk of LV dysfunction or heart failure or arrhythmia. So this is good news for a little bit. Imaging manifestations can be different in women. That's why it's really difficult on the clinical side. That's why CMR complement the early diagnosis for those patients, plays a role in early diagnosis. This is an example of a female patient with Fabry disease. It's X-linked lysosomal storage disease. This patient may manifest later, mild course, lesser degree of myocardial hypertrophy. This patient almost have a normal myocardial wall thickening, low native T1 values, and doubtful enhancement along the basal infralateral wall. And this patient received enzyme replacement therapy, which is good. In summary, CMR is very helpful in establishing the diagnosis. LGE pattern is helpful in patients with differentiating different types of cardiomyopathies. And there is a very important role in prognostication based on the function, based on the morphology, based on the LGE pattern of enhancement that CMR plays that important role. And thank you so much. Any questions for me?
Dr. Fadl, thanks so much for that overview. Really wonderful as always, and very sort of practically helpful in the CMR lab. I see Aditi unmuted. Aditi, did you have a question?
I did, but I can wait until you're done with your question.
Go ahead.
Oh, fantastic. So this is actually related to how the hereditary cardiomyopathy plays out in females. So you had mentioned that there's lower risk of arrhythmias, heart failure in women. I was just wondering if this holds up for postmenopausal women, because I think that a lot of that correlation has to do with women who still continue their monthly menses. And I was wondering if that prognostication changes after menopause.
So Aditi, to be clear, to clarify something, it's lower risk in just patients with iron overload cardiomyopathy, lower risk of heart failure, but not the rest of the cardiomyopathy protocols, because we don't have enough data about that differences. We have enough data for a lower risk of heart failure in patients with iron overload. What I meant is those patients, usually like in patients with Duchenne muscular dystrophy or Becker's disease or other genetic cardiomyopathy, may manifest later. They are X-linked diseases, so women should not be affected in those patients and those diseases, but they may be a carrier for the disease, and those carriers may manifest later in disease these diseases, and you can manifest just with cardiac dysfunction. Like instead of manifesting at the age of 10 years old, they are manifesting at the age of 40 and 50 years old. And just with cardiac dysfunction or lesser degree of extra cardiac manifestations. And those patients, like Becker's disease, they carry a higher risk of female carriers compared to the Duchenne. So in those patients, screening can be helpful, that we can pick and detect earlier disease, like at the age of 40 or at the age of 50, before the heart failure starts or before the risk of arrhythmias develop.
Thank you. Thank you so much, Dr. Fadl. It really was a wonderful talk.
Thank you. Thank you.
Shaimaa, very excellent talk. Thank you for the lecture. I'm kind of like also want to ask about the female carriers. Any role in the screening for strain, like feature tracking or DENS or ECV, calculating the ECV in the screening process?
That's a really good question. I really don't know more. I think there are certain value of T1 values, and particularly with borderline cases like iron overload and Fabry disease. The ECV has been reported very helpful in patients with HCM and cardiac amyloidosis to be higher in certain types. But it's regarding the differences between females, if it's really a value of female carriers, I struggle with even seeing some of the literature highlighting that role of cardiac MRI in inherited cardiomyopathies specifically. But if that ECV and T1 values plays an important role in cardiomyopathy in general between females and males, I think there is some differences. It just, I don't have on top of my head if there is a paper. I think I came across that post-transplant with the heart transplant, that these values may be different between females and males, but I don't know if in general there is a difference.
And in muscular dystrophy, sorry to chime in, there is some literature that says that those are useful markers, although it's an active area of study. So people are, including us, we're looking at that in female carriers because their disease, the rapidity with which they develop cardiomyopathy seems to be slower. And so we're looking at more of those biomarkers to try to predict who's going to develop cardiomyopathy.
Thank you, Frank, for that.
Thank you very much. Thank you, Shaimaa. Excellent lecture again. Thank you.
Thank you, Mo.
There's a question in the chat from one of our fellows, David, who is kind of getting at, choosing between genetic testing versus imaging. I guess from our perspective in the MRI lab, they sort of have already had the imaging ordered. So I guess kind of a related question is, do you have any sense from the literature or just maybe your own personal experience, if when you see in the MRI lab, you know, something that just is screaming genetic cardiomyopathy, what's the hit rate on genetic testing? So many of these conditions, even when they fit the phenotype, you know, might not have a positive genetic test just because we haven't identified the gene yet. Did you come across that at all?
That's another good question. I'm not sure I have a good answer. Let me think about it. It just, yeah, it just, you can, well, I feel that everything is complementary, like what we do in HCM patients. If you have negative test and negative CMR test, it's just based on my clinical practice. But if you have a positive test and negative phenotype, we just tend to follow up those patients closely, like every 5 years or something, to see if they manifested. But I didn't specifically look at the literature for answering this question, but it's a really good question, Corey. I don't know if Dr. Grizzard or the rest of my colleagues have a good answer.
No, I can say for
Shaimaa,
sorry, Doctor.
go ahead.
You can go ahead, Dr. Grizzard. I can comment later.
he was go ahead. He was just agreeing that he's seen that data out there with, you know, the hit rate, but you've got some insights from the HCM type of thing.
For HCM, for the different phenotype, the only one that is like you can by imaging associated with positive gene, about 90% of the reverse curve. The other ones, the most common one, the sigmoid, most of them are negative. So like it's difficult, like really imaging does not like really help in that much in diagnosing like a positive gene test.
So you mean more it's helpful to rule in some of the patients, suspected patients, but with gene negative, correct?
Exactly. And as you said, Shaimaa, like for these patients, you have like a suspicion for HCM and they have a gene test. 70% of the time, they may develop the phenotype and they will never have a positive gene testing. So like you keep like following them up with imaging, whether echo or MRI every couple of years until in the screening period, basically.
Just a quick thing. So the real question in the chat was like, let's say you have an adopted patient that doesn't know their family history, can't even access it, and might have a cardiomyopathy. Well, you know, would you do genetic testing or imaging, blah, blah, blah. And I think that's like somebody who knows more about genetic population statistics could really answer that question better. That's a statistical question, really, right? Because, you know, if they're not symptomatic, what's going to be the hit rate of just randomly scanning somebody or doing genetic testing? It's going to be low. I think my answer to this question would be, you know, follow them clinically, and if they develop any symptoms of heart disease in any fashion whatsoever, then I think imaging would be fine. And then because I think imaging would allow you to pre-specify what you think they need to have genetic testing for. I mean, otherwise it could be kind of endless, right? So, but you know, let me be clear. I have absolutely no literature to support what I just said.
Thank you.
All right, well, we've reached the end of the hour. So thanks again, Dr. Fadl, for a wonderful presentation. And just a plug for next week's session is a case sharing day. So if you've had any interesting cases coming through your lab, let us know. We'd love to see them.
Thank you so much, Corey, and everyone.